Happy New Year, CTSNet friends. So, on this episode, we thought we would summarize the whole of 2024. So, as well as a few interesting articles that are on CTSNet this week, we're actually going to go through all the top picks that we've been publishing over the last couple of weeks, which summarizes a fantastic year that we have had at CTSNet. Remember, we did 420 videos this year, more than we've ever done before. Loads and loads of Jans, really popular. The most hits we've ever had, 5 million hits this year, and it's all down to you. So thank you so much for watching and watching this podcast, coming to CTSNet, seeing the videos, and most of all for contributing, because we couldn't do it without you guys. So stick around and I'll take you through the whole of 2024. So for this week's podcast, I'm going to do it a little bit backwards because we do have a few new articles out on our website this week in Jans. There's some interesting ones. Cutibacterium acnes for active endocarditis. It's a new pathogen that is becoming more common. Long-term outcomes for antegrade stenting in type 1 dissection. An interesting transplant one. Should you transplant the right or the left lung first in transplantation? And a nice reassuring paper on patient prosthesis mismatch. That's what's on the Jans this week. But before we do that, I'm going to spend most of this podcast going down my 1 year of memory lane to see what we did in 2024. And it seems like such a long time ago, January of 2024. Now we're at the end of the year and starting 2025. This is in fact episode 86 of the podcast, which is really great. Thank you so much for listening every week. I don't mind if you miss a few weeks. I don't mind if you don't get to the end, but thank you anyway for supporting us. It's gone from strength to strength, which we're so pleased about. So really, we've had a great year. As I said in the introduction, more videos we've ever done before, more series, more Jans, a wonderful senior editors team, a wonderful Jans team, and wonderful contributors from people like yourself. And one of the things that I really love is how international we are. We've had some really great videos from Latvia, from Ukraine, from India, Bangalore, Australia, and of course America and Europe. So we really are seeing so much brilliant stuff from all over the world. And the thing that blows me away is some of the most highly technological robotic videos come from places you don't expect, because people are innovating, which is what we love to reflect. And I think one thing we love in CTSNet is getting things out quickly, and not having a 5-month review process and lots of other people sort of sending you videos back. If you've got a great video, we try and get it out. We get our review process down to 2 weeks now. So you'll get a turnaround and an answer that quickly, and we hope to get it out shortly after that. So let's see what was fun and exciting and new and amazing in 2024. So we've got a few categories for the most popular. The most popular interview was with 2,083 views, Lars Svensson. And this was when I went to the Cleveland Clinic and spent a very happy 3 days there, watching some amazing operations, but also had to interview Lars Svensson. Now, I guess if you had to guess who would have been the most popular interviewee, it's got to be him. He is chair of the world's best unit, the Cleveland Clinic, 5,000 operations a year, voted 29 years running best unit in America. He's also president of the AATS, so really there's nothing he hasn't done. He's a tremendous guy. He's got outside interests. He loves sailing. He loves taking incredible photography, and just a great guy. And of course, this year he led the AATS conference, which had none other than Arnie Schwarzenegger as the speaker, which was really fantastic. So we did a great interview with him. It was super popular. It was mostly about his technique for aortic valve sparing root replacement, and a little bit about the Cleveland Clinic as well. And it was really wonderful to see him actually operating. Sometimes these guys that run our specialty, you forget they operate because they're so busy running the specialty. But of course, he's an absolutely fantastic Marfan surgeon and a valve sparing root replacement surgeon. So some really good, sensible hints and tips from him. And it was great to join him in his operating room. And if you were ever looking for doing a few days somewhere, I highly recommend just going to the Cleveland Clinic for a few days just to watch. There's I can't remember what the number was, something like 27 operating rooms all running concurrently. They do 25 operations a day. You can literally look on this board and just go and see whatever you'd like to see. There's a dissection every other day. There's a transplant a couple of times a week. I mean, it is a great place to go and watch, and they're tremendously collaborative and really friendly and welcoming, and work together really, really well because they're at the top of their game. So better move on because it's really busy this episode. We got loads of best ofs. The most viewed clinical video, 4,901 views. It was tips, tricks and pitfalls for cardiopulmonary bypass. You're going to hear this name again, but Stephen Spindell was smashing it out of the park for us in 2024. He did several of our best videos, but this one was just really great, especially for, say, an early career surgeon or somebody just coming to the specialty, doing their first procedures, and especially starting to put people on bypass. It's really nicely narrated. And basically goes through everything. So it talks about aortic cannulation, it talks about the basics, how to put the purse strings in. It also talks about epiaortic ultrasound, how to miss aortic calcification, what to do if you find aortic calcification, other sites you could maybe cannulate if you find this as a problem. Looking at Seldinger techniques as well. Talks about stab and go and a few other techniques for the actual cannulation as well, which is nice. Talks about simple things like checking the arterial line for pulsatility, giving a bit of volume from the perfusionist, and if you get a sudden massive rise in pressure and no pulsatility, what to do if you're worried that it was a dissection. Talking about the purse strings, he talks about lots of other things as well. So venous cannulation, little tips like don't ever cannulate the aorta until the pressure's under 110, auxiliary cannulation, venous cannulation, the works. So really, really good. If you're a trainee and you missed this, it's called Tips and Tricks and Pitfalls for Cardiopulmonary Bypass. Go and join the 4,900 other people that watched that video in 2024. We've really got to a great place with JANS, Journal and News Scan. We've got some great people working with us. They're called our JANS editors. Anybody can be a JANS editor. What are the rules for being a JANS editor? Well, you come on our list, and each year starts at I think it's April we start it. But anyway, we then set a counter going. And if you submit an article a week, you get a tick in your box. And then the top 5 people that submit for the most number of weeks get a $1,000 prize. And the top 5 get it. So it is really, really good because we're getting loads of submissions from our great JANS editors, and you can literally join it if you like. We've got a good number of them, but shout out Jessica Luke. She's winning at the moment. The year isn't by any means finished, but she's done 23 submissions. Akshay Patel, 18 submissions, and Matteo Martin Cortes, who has 15 submissions. They're in the top 3 spots for the $1,000 prize when we finish the year. And so the best JANS article of the year was, drumroll, multi-arterial versus single arterial coronary surgery. 10-year follow-up of 1 million patients. What a great study. Joe Sabick led this one from Cleveland Clinic, the upcoming president of the SDS. We'll get that handover in Los Angeles very shortly, and lovely guy, and on our board of the SDS. So, and this really is a fantastic paper. Obviously, it's got everybody else on it. So from the SDS, you've got Patrick Mars, Vinay Badwa, Joe Chikwi, Tom McGilvery, and many, many others. David Taggart, John Puskas, Faisal Bakeen, the gods of revascularization. And as I often say, we should acknowledge revascularization surgery as its own specialty, just like mitral aortic surgeons. You should have a revas surgeon in every unit that is an expert. And this paper really is very impressive. It really did a deep dive into whether just a lemur and vein grafts or multi-arterial grafting will help. And actually, I think it was really very balanced. It was 10-year survival rates. It's from the STS database, and multi-arterial grafting was found to have an overall survival advantage in all subgroups, and superior survival with single arterial graft was only associated with people who have a body mass index over 40. So really, if you haven't got a huge high-risk person for BEMA, then really it is saying that 10-year survival is better with multi-arterial grafting. But do take a look at that paper. It's real world. So we've got RCTs that David Taggart ran. We've got this 1 million patient cohort trial. How many more do you need? And I think we really have the evidence to go towards total arterial grafting in patients that aren't huge or ancient. We've really delved in very deeply into guest editor series this year, because we find if we find a world expert and they can get their friends together and they can make a few videos, then it really does provide an excellent group of videos for an interested person. And out of all the guest editors series we did, the most popular with 3,574 views was the series put together by our very own Lorena Montes from Colombia. She is our cardiac senior editor. Hi Lorena, you're also awesome and super enthusiastic, but she put together some great videos in aortic root surgery. So the ones were one by, some of you may have heard of him, Bo Yang, update on the Y incision, aortic annular enlargements. If you've seen his videos, they're absolutely brilliant, tremendously persuasive of how you need to increase the annulus, but how easy it is using his Yang technique. There was a nice one by Gustavo Prieto, porcine xenograft as an alternative to homografts in the Ross procedure. There was a really great one by Alberto Forteza Gil, aortic valve reimplantation in a Marfan's patient. A beauty aortic root replacement with biobentals by Maral Uzunian. And then the most popular one in the series, I got to video it because I videoed a colleague called Mazi Kanani. He has coined a new phrase called the chrysalis technique, and he has a new way to perform an aortic root replacement. This got a lot of interest because what does he do? Well, he opens up the aorta, but he doesn't take buttons. He leaves the left main stem and the right coronary artery in place. He then just puts the biobental in like just a normal valve replacement. Does a second line of sutures to make it hemostatic, but then he punches a hole and just stitches the left main and the right directly onto your biovalsalva, which saves a lot of time. And also then he does the distal anastomosis, but then he rewraps all this redundant aorta around the prosthesis to kind of reduce bleeding, really. Now, it got quite a storm of responses from some people going, yay, that's so original, that's brilliant, to that's terrible, that's the worst thing ever in the world. And in fact, some people did actually mention that Bentl's original description did have this as a technique. Some people even warned that if you wrap around the old aorta around your prosthesis and there is bleeding, you actually get a hematoma on the outside that squishes your new prosthesis closed, which sounds quite dramatic. So really interesting. I think whether or not you use it as a hemostatic layer, maybe you should put a little puncture in it or something. Still, it was quicker by not having to tape buttons, and I believe safer because you didn't have to go around and tape buttons, and the orientation is just right. So I think this chrysalis technique is great. I think with Mazi, we're going to have a go at doing some new ones. So if you like aortic root surgery and you want to watch a few more of these, then stay tuned for 2025. Now, top contributor to CTSNet. Some competitions, there's one person that's just so far out in front, it's not even worth talking about second, third, fourth or fifth. And this is the situation this year. Our knock it out of the park, by far top contributor by absolute miles, is the one and only Vince Gaudiani. This completely fantastic surgeon, who I love listening to, is just providing us with so many outstanding videos. Now, I would like to say a few more things about Vince, because firstly, rudely last week, I told you that every senior editor gets $5,000 as a thank you for all the hard work they do each year. He refuses his. He refuses to take what he should be getting and what we'd like to get him to say thank you. Secondly, he did 30 videos last year, and also he pays for all his own editing from a professional company. I'm not even going to tell you how much they are, because it's unbelievable. And he's just doing this because he believes in education. And so absolutely phenomenal. He's totally brilliant. He works at Pacific Coast Cardiac and Vascular Surgery, Mountain View, California. He's got so many ideas for 2025, including there's a new mitral series. I've just watched his mitral replacement when he had to rip out some old mitral clips that had torn through a mitral valve and some extra cord he had torn. He thinks this is going to start happening more and more. So that's a great video. There's lots more of those. He's got an aortic series coming as well. He's got a how to do good surgical video series coming. So literally he's brilliant. And as well as the 30 videos he did, he also appeared on my podcast, and he appeared on the Atrium podcast. And you'd think that this is because he's retired, but he hasn't. He's working. He's doing loads of operations still the whole time. So I don't know how he does it, but he's tremendously appreciated. He's 2024 CTSNet magazine Man of the Year, I think. If we had a front cover, he'd be on it. Just one little thing, just to mention, probably his best video out of all of it is proving to be CABG with a long LAD endarterectomy. It's actually only just come out, but it's already had 1,500 views. It only came out on December the 23rd, but everybody's watching it. It's super good. It documents how he had to do this massive long endarterectomy. He had to take a piece of vein to roof over this huge endarterectomy. Then he puts the lemur onto this patch LAD. Really nice narration, really well done. Obviously not for the faint-hearted, but if you are going to do your first one, definitely watch this video because it would really help you out. So, we've got lots more to get through, so don't go away. So, top cardiac procedure videos of 2024. As we've already mentioned, the very top one was that Tips, Tricks and Pitfalls from Stephen Spindell. But the next one after that was also a Stephen Spindell one. And this was one I really liked. Breaking the Dogma in Aortic Valve Replacement, the 9-suture AVR technique. We were actually interviewing him about his hemiarch video that he'd won one of the CTSNet competitions about, and I said, what have you got coming up? And he said, well, Joel, I don't know why everybody puts all their aortic valve sutures next to each other. You know, when you're stitching a seam, you don't do that, and you leave a space. That I leave a space. I leave as much space as I do horizontal mattress stitch. And I'm like, never. That's crazy. He said, crazy? I've been doing it for a decade. And so this is that video. Crazy thing, but actually it's fine. You don't get a paravalvular leak. It saves loads of time. You're down to 9 sutures, and just take a look. It's super quick. If you want to speed up your aortic valve replacements, maybe you've got an AVR and 4 grafts to do, you just want to bang that valve in nice and quick, go for this technique. It will save you some time. And actually, you know, maybe you could just leave some little spaces, then bigger and bigger and bigger, and go before you go to all the way to a space as big as a suture. But this video, I think, will give you the confidence, and 4,626 people viewed this, and I wish I could reach out to all of them and see how many of them have started spacing out their aortic valve sutures. That would be really interesting. In third place was Total Arch Replacement with a frozen elephant trunk, 3,000 views by a German Fortunato, and this was a really nice hybrid approach video. This was using the Evita Open Neo to get that hybrid approach, so total arch, and then dropped the elephant trunk down in the aorta. By the way, links to all these videos, if you want to check them out, are both on the CTSNet front page under the top 5s and also in our show notes today. The next video, which was neck and neck with the previous, was probably one of my favourite. This was the world's first robotic heart transplant by Faras Khalil at King Faisal Hospital in Riyadh. If you haven't seen it, you've just got to see the world's first robotic heart transplant. I need to actually email him and see how many he's done now. He's probably done 5 or 6 now, but I thought it sounded mad, but when I watched the video and talked to him, it just makes so much sense. He took a really young guy, I think he was 18, who had a massive pericardium, took out the old heart because he does all his surgery through a right heart robotic technique. And as we all know, we've been getting loads of videos on aortic and mitral replacements and repairs through a right-sided technique. So if you can cut the aorta and you can cut the left atrium, then you're nearly there. Just chop the pulmonary artery and out comes the heart, leaving the big left atrium. And actually, the real magic is that there's a huge pericardium because you've got dilated cardiomyopathy. So you bung your little tiny donor heart, which is completely empty of blood, so it fits through a 4-centimetre incision, plonk it into this big pericardium, suture the left atrium, then put the pulmonary artery on, then the aorta, then SVC, IVC, you're done. And it looked brilliant. Great 10 times magnification. Obviously, the robot is a stitching machine, so it's designed for this. Great job. I know this has become a super common technique, so that was a great one, which I loved. And the last best video in cardiac was another super scary one, the commando procedure in a patient with aortic and mitral valve prostheses with endocarditis, 4th intervention for bacterial endocarditis. So Domenico Mangino, Paolo Magaggina and Stefano Ciccio. Sorry if I butchered your names there, but they were seriously impressive. 30-year-old lady, commando procedure, 4th intervention, opened everything up, literally just looked like a bomb had gone off in the middle of the heart, and reconstructed everything. Double patch repair, making new annuluses for the mitral and aortic valves. Really nicely done and super popular with 3,000 views. Phew. So that was best content of cardiac. Now, we ask every year for our editors to come up with their favourites of the year, and so Sami Syed has named a few. The first one was Amir Al-Kasawi from Iran, who did a subaortic membrane resection and septal myectomy, which is really nice. 9-year-old boy. And really nice done. Very clear, very obvious. Left ventricular outflow tract gradient of 120 millimeters of mercury. That's not great. And really nice, clear video. Beautifully done. The second one was by Alan O'Donnell at the Cincinnati Children's Hospital, regular contributor. We've talked to him about how to do beautiful videos, and this was a beauty. Nice and simple pediatric orthopedic heart transplant, orthotopic heart transplant. So yeah, really nice video, and if you wanted to see a nice transplant, that is your one. We had a few nice thoracic favourites. A diaphragm plication, simple and effective uniportal technique was published, which got 1,700 views. People seem to like it really nicely. It was from Riga in Latvia, and didn't use CO2. I love using CO2 in 3 small ports, but actually this shows that this technique is just as good. I always wonder whether it's quite difficult to push down the diaphragm if you don't have CO2, but very popular, very simple, nothing difficult at all. Simple knife and fork to do a diaphragm plication. Well done. A emergency bilateral thoracotomy was popular. This was by Dr. Villanueva, and actually is a cartoon form of how to do a bilateral anterior thoracotomy or clamshell thoracotomy. Of note, we actually in csuals.org, which is a course I help run. We've got a whole how to do an emergency thoracotomy course with e-learning and 8 modules. We've actually got loads of live videos, either cadaveric or actual to patients recorded of how to do thoracotomy. So if you do want to see some resus training and some emergency thoracotomies, let me know. I can send you the links to that if you like. A few more Jan's articles that were the best. The one I really liked best was 10 Commandments for Proximal Anastomosis during CABG. This got 1,700 views and just went through loads and loads of really interesting hints and tips. And this was with John Puskas, the god of revascularization. And so he talks about doing a nice anastomosis, but he talks about why don't you use a heartstring or an enclose or a viola so you don't have to clamp the aorta. What about doing piggyback anastomoses? If you've got 3 or 4 on the aorta, just do 1 onto the aorta and then the other 3 onto that bit of vein, which I hadn't actually heard of. What about other places other than the aorta? Axillary, carotid, subclavian. Which again I haven't seen done very often. Transit time flow management he thinks is really important. Epiaortic ultrasound, really important. Radio opaque markers around all your top ends, something I actually suddenly, when he mentions it, I'm like, yeah, that's just so sensible. Just be so nice to your cardiologist, because it is difficult for them to do an angiogram if they don't know where your top ends are. It takes 2 seconds while you're waiting for the protamine to kick in. So full of really, really good hints and tips for top ends, and available below in our show notes. The other Jan's post that was really popular was revisiting aortic valves prosthesis choice in patients less than 50, the Orth Heart Visit 10-year results. This was a huge analysis from Austria of nearly 1,000 patients, looking at whether they had mechanical or biological valves in the age under 50. It's kind of crazy to think that people younger than me are having biological valves. I think I definitely have a mechanical valve, and actually this had a bit for everybody. It said your operation-free survival was decreased with a biological valve. Your risk for your reoperation was increased by 3 times, but actually the overall survival was the same in both groups. Now, you may have seen some of the videos with the wonderful Enoch Okoa, who is now president of our society, after he was on this podcast, by the way. I'd just like you to know that. I feel a bit like the Joe Rogan to his Trump, as I did a podcast and then he became president. I think he's quite good anyway. But actually, one of the things he says is we need to fight a war of mechanical versus biological in the sort of 50 to 60 age group, and do a big, massive international study on whether it harms people to have a biological valve. Because if it is better to have a mechanical valve, that at least preserves these people for surgery. And this paper kind of does support the idea that actually in a bigger study you probably would get a mortality benefit. A few others that were really good. Cardiac surgery after TAVR, trends and outcomes. That was quite a good one, because it is much higher risk. Basically, it's kind of crazy risk doing cardiac surgery after TAVR, which is quite interesting. And then transcatheter or surgical treatment of aortic valve stenosis was also a very popular one. We did a few editors' picks, so I won't go through all of them, but they are all on the editors' picks 2024, which is going to be published on January the 3rd, which is probably any time now. And my picks, I really liked Jill Lay's interview with an amazing guy called Donald Hill. He's a surgeon right at the dawn of cardiac surgery, and gives some wonderful insights into what it was like in those crazy days of the first operations, when they had to take blood gases by stabbing your femoral artery, and didn't have invasive arterial monitoring, had blood pressure cuffs on afterwards. The average age of a revasc was 50 years old. So really, really good. And actually the other top pick I had was Landmarks in Cardiac Surgery by Stephen Westerby at the London Core Review. If you kind of thought, well, I'd just love to watch a video all about, what were the landmarks in cardiac surgery, then Stephen Westerby, who actually has written a book all about this, really does go through this in great detail. And he's a great speaker as well, so I picked that as well. Another video I picked was one of Tristan Yan's wonderful deep dive into total arterial anaortic off-pump coronary artery bypass graft. grafting. He just sent a set of wonderful videos in showing how you can do beautiful off-pump surgery without touching the aorta at all in a really relaxed fashion, with some gentle music going along as well. In fact, it was about one of the only videos we allowed to go through with music, because we don't tend to like it, but it was so nice we let them do it. And of course, I couldn't not pick one of Vince's videos, and really the biggest splash I thought he made this year was safe cerebral protection, showing us his technique of carotid artery cannulation, and then selective cerebral perfusion, so that you can clamp the carotid artery, basically turn off the rest of the body, not cool down the rest of the body, keep the body warm, keep the brain cold, and then you can literally do anything you like because the brain is protected. And then he went through a whole load of different operations: emergency dissection surgery, multiple redo surgery where you saw straight through the right ventricle. All that doesn't matter because of his safe cerebral protection. If you've missed that technique, literally straight away go to one of his videos, because it will blow your mind. And the next time you're doing a dissection or watching someone else, literally, why aren't you doing a separate circuit, 1 litre a minute to the brain, cooled to the brain, and leave the rest of the body warm? It makes no sense to do it any other way, in my view, as a thoracic surgeon. So well done. Those were my picks. Just a few other picks. Leanne Afrafian picked a few other good thoracic ones. A really nice robotic-assisted first rib resection is on there. Lung auto transplantation. Did you miss that one? This 45-year-old patient had a metastatic testicular cancer, had bilateral tumours, an enormous tumour on one side and a little tumour on the other. So they did a big clamshell, but also they just couldn't get round the tumour. So they literally took the lung out, operated on the bench, and then put the whole lung back in after having done the operation, preserving the lower lobe and putting it back in as a sort of auto transplantation. Super clever, and just something maybe you should have in the back of your mind when you are doing very difficult, huge cases rather than a pneumonectomy. And one other one she picked was a robotic repair for an intraoperative tracheal massive tear. This poor Dr. Guat and Dr. Patil, they were just doing a simple right-sided operation when they discovered there was lots of blood coming out the ET tube, difficult to ventilate. They had to look down, massive tear in the trachea, and then there's a great video of how they fixed it. So Lorena Montes, she picked a few good ones. I'll just start whizzing through them because you're probably wanting to get on with your day, but she picked some really good ones. Totally thoracoscopic left atrial maze procedure, which I really like too. Felt plug for an LVAD explantation, a nice easy way to plug the hole, the ventriculotomy after an LVAD removal, and surgical extraction of a watchman, which can be super difficult. And then she really liked the undressing the full metal jacket, a case report of a coronary stentectomy, a bit like Vince's LAD, long end arteriorectomy. This great video shows a massive long stent being taken out, ripping the LAD to pieces and then reconstructing it. Not again for the faint-hearted. And our wonderful global editor, Emily Farkas, chose some of the global content we featured this year. One of our episodes was Cardiothoracic Surgery in Iraq. That was Beat episode 71. That was quite fun when I was over in Iraq this year, seeing the great people there. And they do really great heart surgery, so it was good to see. We covered the mobile surgery unit in Ghana in episode 68. Obviously, Diego Gonzalez Rivas now has a mobile unit doing thoracic surgery there. She really liked episode 50 of The Beat, our episode on work-life balance, which, considering it's a Sunday 2 days before New Year, I don't know whether I'm getting my work-life balance right doing this podcast, but I consider this fun chatting to you guys. And she really enjoyed 2 of the atrium episodes, cannulation and the basics of thoracic surgery. Mara Antonoff is our diversity, equity, inclusion editor, and she has told us all about her picks, which was some webinar recordings, state of gender representation in CT surgery around the world, women as leaders in cardiothoracic surgery, and fighting inequities in cardiothoracic surgery. And so that was really nice. So that was our summary for 2024. I'm sure it's going to be a really, really good year in 2025. I'll just, for the last bit, just mention 3 articles we have this week on our front page, just in case you're interested. The first one is by Shekhar Sahar and Kristin Hagel, European Journal, published this month. Cutibacterium acnes, infective endocarditis, emerging pathogen. They basically had a look at a load of 8,812 patients having surgery for endocarditis in their German database, and they found that Cutibacterium acnes is the cause for endocarditis in 3%. And actually this is a growing as a pathogen, or the realization that it's a pathogen. Interestingly, I was just at a conference where we were looking at pathogens for pain in pectus procedures, where the NUS bar is causing a load of pain. And loads of them were Cutibacterium acnes. And there was a big paper all about how patients with lots of pain, they then swabbed as the bar came out, and they had loads of Cutibacterium acnes, and those people without pain didn't have it. So clearly there's this rather dodgy bug that is slow, not causing masses, loads of pus, but causing endocarditis, causing pain, causing gentle bits of mayhem that we're probably ignoring on our pathology results. And it's also quite difficult to grow. So I thought that was very interesting that across the specialties we're finding this as a bug. Second paper, Nimesh Desai, Annals of Thoracic Surgery, long-term outcomes of antegrade thoracic stent grafting during repair of acute DeBakey type 1 dissection. Nimesh Desai works in Bern, Switzerland, and basically this was looking at 733 patients with a type 1 dissection not having an arch procedure, and 95 had antegrade stenting and 638 didn't. And basically the question of this paper was, does it matter or not? And the quick answer is the survival was pretty similar. The 10-year survival was exactly the same, really. And then the incidence of reintervention was a little bit different, 27% versus 22%. But actually, basically, no survival difference for 10 years and only 5% difference on reintervention. So maybe you could take it or leave it if you're going to think about doing antegrade stenting in a type 1 dissection. And the next paper was an interesting one because I never really thought about it. Normally, if you're doing a double lung transplant, you'll probably do the worst lung first. But Laurens Schulemans, a fantastic surgeon from KU Leuven in Belgium, is a thoughtful guy. And he thought, what about just doing the right all the time? Because actually that gets the most cardiac output, and so maybe you'll get less damage as it's reperfusing if you do the right first compared to the left. So he just started doing the right first rather than the left if it's the worst one. So they had a look at all their transplants, and they looked at when the left lung perfusion was less than 50%, so people they'd more normally do the left first, and the right was done first in 219 patients and the left first in 189. Huge numbers. And actually interesting, escalation to ECMO was observed in 10% if you did the right first versus 20% if you did the left first. So actually the guy's a genius, clever guy. Do the right first all the time. Don't do the worst lung first. So very clever paper, loved it. And the final paper, getting to the end now, was a paper by Antol Prinzing in the Annals of Thoracic Surgery this month. He's also from Germany. Patient prosthesis mismatch on long-term outcomes. We get a lot of papers from patient prosthesis mismatch. Obviously, Bo Yang would tell you it's the worst thing in the world, and this paper has its own view on it. 645 patients, biological aortic valve replacement between 2000 and 2007 to allow for a decent amount of follow-up. They defined prosthesis mismatch as an indexed effective orifice area less than 0.85 on echocardiographic follow-up. And PPM was present in any type, and 40%, 175 moderate, and 81 had severe. So actually, the results were a little bit reassuring. That the 10-year cumulative incidence of reoperation was 8% in the no mismatch versus 12% in the severes. And actually, there was only a marginally significant impairment of survival between the none and the severe. And so actually their conclusion was that actually the patient prosthesis mismatch was only marginally related to long-term survival and not statistically significantly related to the risk of reintervention. So they're being pretty reassuring about it, even in that severe group. Phew, well, that was a lot to get through. Sorry if I jumped all over the place, but I'd quite like to just give you a little flavour of what we've been doing all this year. In upcoming events, of course, there can be no bigger event than the STS in Los Angeles Convention Center. It's the 24th to 26th of January. We'll be there with pretty much most of our senior editors. And so, yeah, we hope to meet you there. We have a CTSNet booth, so do come up and say hi to me or Marita. I'll probably be there for most of the conference perhaps, so that will be fun. We'll do some videos of important people and fun people, exciting people like you. Maybe come up, we'll do an interview, get you on a podcast. That'd be fun. Don't forget that there is a resident videos competition going on, deadline 10th of January, but there is a prize, a $1,000 prize for the winner, and that will be great. And finally, Happy New Year to my VIPs. Of course, I hope you know by now that my VIP club is purely for people that survive to the end of this rambling podcast. But if you've survived, thank you very much. If you want to be part of my VIP WhatsApp group and you're not already, just WhatsApp me on +44 780 154 8122. And we've got a nice little group there. People sometimes just post great things they're doing. I post when the minute that the podcast has come out, and Marita did this this week, just so you know when a new one lands. They usually land on a Thursday, so you've got the weekend to listen to it, and do post back any interesting topics. I did get a topic actually from... There's this European review of British transplantation for heart and lungs. It was absolutely shocking. It was terrible. Basically, the UK is just about the worst transplanter in the whole of Europe. I think I don't want to be rude, but I think we're next to Slovenia in our rate of transplantation. It's absolutely terrible. It's been dropping for years, and basically it's kind of a call to arms. It says that certainly for lung transplant, we should get a lot more lung surgeons to do it, because most transplant surgeons are cardiac, they do lungs, so they reject them a lot. The rejection variation is huge, and you know we are getting a lot of things wrong in Britain. But it was a really interesting report, and it was really interesting to know that the ISHLT do go out and do country reports to look at the state of the nation of transplantation, to try and bring up the quality of transplantation. So thanks for that tip, VIPs, and a shout out to you, and thanks for listening. So we will be here every single week next year. Thank you for listening, and I hope to bring a few new types of videos next year. We're going to do Vince's special dives, basically one-on-one with the editors of the videos. We've got a few other ideas that we'll share with you as well in 2025.